Hello everyone and welcome to this special live webinar on the MedSynapse platform. I'm Hetvisha, your host for today, and I am absolutely thrilled to have you all join us as today we are diving into an incredibly important topic, which is supporting children with type 1 diabetes for building a better future together. And who better to guide us through this conversation than our esteemed guest, Dr. Peerzada Ovais Ahmad. Dr. Ahmed brings nearly a decade of experience in endocrinology with a specialization in youth onset diabetes, maternal endocrinology, and cutting edge diabetes technologies like CGM, CSII, and NDI. He's been instrumental in establishing the Youth Onset Diabetes Registry in Jammu and Kashmir in India and is collaborating with Professor Bruce King at John Hunter Children's Hospital in Australia to develop diabetes management program that prioritizes optimal glycemic control and quality of life for patients and their families. Dr. Ahmed has also spearheaded initiatives like the Life for a Child program at SKIMS in Srinagar and has led groundbreaking research, including India's largest randomized controlled trial on vitamin D supplementation during pregnancy as part of his PhD. So, Dr. Ahmed, welcome, and it is such a pleasure to have you with us today.
Thank you, Etvi, for giving me yet another opportunity to talk on your platform. And the topic that you have chosen today is very, very close to my heart. And I have worked almost a decade on type 1 diabetes, helping children and families about type 1 diabetes and so many things. So it's really an honor that I finally got an opportunity to discuss about this topic and how we can make future of the children better with type 1 diabetes.
Thank you, Doctor. It is a pleasure. So before we start discussing this topic, Doctor, one question for you would be, can you share some of your insights in endocrinology, especially your work that you've been doing?
So yes, so in type 1 diabetes, like we belong to a place where it's considered as low income country where the resources for type 1 diabetes are very limited. When I say resources, I mean access to free insulin, access to blood sugar monitoring, access to diabetes education, which is not that great. So what I have done in last 10 years is that we started making insulins available free of cost to almost 500 children, young children and adults less than 25 years of age, those who are following at Sher-e-Kashmir Institute of Medical Sciences. Not only that, we also got them free glucometers and testing strips, so they check multiple blood sugars daily. This was funded by Life
This
for a
meeting
Child
is
program
being recorded.
that we will discuss in this meeting, how I got it into the place. And later I went to Australia as my fellowship. I did fellowship in pediatric diabetes at John Hunter Children's Hospital, Newcastle, Australia, under the supervision of Professor Bruce King. So we brought pediatric diabetes management program, what they call SWIM, Success with Individualized Insulin Management. So we implemented that program into our settings and saw how it will help in improving diabetes outcomes. So maybe I'll talk about that in detail later. So mainly just helping children and families with type 1 diabetes. You need to have a passion to treat type 1 diabetes. Type 1 diabetes is not everybody's cup of tea. You may be treating thousands of type 2 diabetes, but when it comes to type 1 diabetes, entirely a different disease altogether. So you need to be very committed, you need to be very passionate, and you need to have empathy for these families.
Yes, thank you. That is actually very incredible, Doctor, and thank you for sharing that. Now, Dr. Let's start with a question that addresses some common ground. So, from your experience, what are some of the biggest misconceptions that doctors encounter when managing type 1 diabetes in children?
Very good question. So there are so many misconceptions related to type 1 diabetes. So when it comes to diabetes in children, the biggest misconception that the people have is that children cannot get diabetes. So when we announce the diagnosis, it is very difficult for families, their parents to accept that their child can get diabetes. And second, when we tell them this is a different type of diabetes where you need to you have to be on insulin lifelong, multiple insulins. And this is another misconception, why you are putting small children on insulin injections. Why can't we treat it with tablets? Third misconception, commonest, is that, oh, our child was eating too much of chocolates and sweets. That's why they got type 1 diabetes. And third thing is that they would ask that, would there be a time where we can stop insulin? And with these misconceptions, many of the families, they go to people who are not qualified, or I would say quacks, who give them very false hope of reversing their diabetes, in fact, stopping insulin. And then we know what happens. They come back to us with severe conditions like diabetic ketoacidosis. So biggest misconceptions, first, not accepting the diagnosis, then not accepting that insulin is the main, or I should say the only stray of treatment for type 1 diabetes. And then changing, doctors, or even they go to multiple doctors. Maybe some doctor would tell them we can do it without insulin. And of course, blaming lifestyle, like he was taking a lot of chocolate or sweets. This is also one of the common misconceptions that we encounter in our clinical practice.
I think that is such a important point to consider, and actually it also highlights how essential awareness and education is, and especially the right kind of education to spreading their to their families is also really important.
So just want to add one point here, like the first thing that you tell to the family, you have to give a very correct and a very clear scientific evidence-based message. You should not give any false hopes. You should say what type of diabetes this is and why it has happened and what is the treatment. So what you tell them on the first day of the diagnosis is something that they will take it for their entire life. So you have to be very careful in using words. So you should never give any false hope or any kind of information which is not true. So whatever we know, we should give as per the evidence based. So they will take it their entire life. If you tell them something wrong, no matter if we educate them later, it's very difficult for them to convince, because they will always say that somebody told us that this can be done and that can be done. So right education, to the point education, is very, very important.
Yes, I think for healthcare providers as well, it is so important to spread the right kind of knowledge and awareness to the families, especially with type 1 diabetes in children. So now, Doctor, many of our attendees today are pediatricians and endocrinologists. So could you shed some light on the latest advancements in insulin delivery systems or glucose monitoring devices that they should be aware of?
So we have come a long way from the time when insulin was discovered in 1921 by Benting and Best. So that was, insulin was basically discovered for management of type 1 diabetes. And there has been a lot of advances, right, from giving insulin through a syringe, then going to a pen, and then we have devices what we called insulin pumps. Now we have insulin pumps called as automated insulin delivery, AIDs. Examples are 780G by Medtronic. That works like a artificial pancreas, which is connected with a device called a CGM, continuous glucose monitor, which is there is a sensor on your arm, and this is connected with your pump and with your phone. So this is called as closed loop. So this sensor tells the pump about the blood sugars. So it automatically releases insulin, or it suspends the insulin delivery if the blood sugar is low. So insulin pumps are new. Then we have continuous glucose monitors like Libre. We have in India we have Freestyle Libre. Outside we get Dexcom. Also, we have some patch pumps made by Insulet called Omnipods. These are use and throw pumps. So these are the latest technologies that type 1 diabetics can use.
Yes, I think it is so fascinating to hear how actually technology is evolving to make life easier for both, actually, for children as well as their families as well. So now, Doctor, managing type 1 diabetes is as much about lifestyle and education as it is about medical interventions. So, what strategies can doctors implement to improve glycemic control without overwhelming the child or their family?
So, see, in my practice, in my experience, the best thing is to spend time with the families. You have to give them education. You have to spend time. You have to talk about a concept called as carb counting. First, you have to tell them what carbohydrates impact your blood sugar levels. And then you have to make them understand that we need insulin for these carbohydrates. Then we have to make a simplification of carb counting, like what I did. Maybe we can discuss it in some time. That we made photographic carb counting resources from the place I belong, Kashmir. So we have a lot of varieties of different types of breads and containing different types of carbohydrates. Then giving appropriate dose of insulin as per the blood sugar and as per the carbohydrates you eat. So it's about basics, telling them about insulin. So first of all, educating them about types of insulin. So normally we have, in type 1 diabetes, the management is basal bolus. So you give 3 times bolus insulin, like insulin, regular insulin, or it could be something like Ectrapid or Fiasp, or a long-acting insulin like Glargine or Degludec. So we have to explain them the bolus insulin controls your postprandial sugar, and the basal insulin controls your sugar between meals and fasting blood sugar. Then you have to teach them about how to inject insulin. It's very important. Insulin injection technique is something that I would say 80% of people still do not know. Even some doctors, I myself, I'm still learning how to give insulin injections. Then rotating the insulin injection sites. Then most important is monitoring. You have to, this type of diabetes, you need to monitor your blood sugar multiple times a day, at least 4 to 5 times a day, if a blood sugar monitor is available or testing strips are available. So it's about mostly education, talking about basic things. And you need to have a multidisciplinary team. You need to have a doctor who is an endocrinologist, or pediatric endocrinologist, or adult endocrinologist who sees type 1 diabetes, or a pediatrician. You need to have a specialized pediatric diabetes nurse, or a dietitian. Then you need to have diabetes educators. You need to have diabetes psychologists or social workers. Those things we are still behind, but these things I have learned when I was in Australia. They have a complete team for management of diabetes. But in our place, it's basically the doctor who takes care of each and everything. So I think most important, I said initially, is giving a lot of time and spending a lot of time with the families. That helps them a lot.
Yeah, that is rightly mentioned. I think multidisciplinary team approach is something that all healthcare providers and hospitals should look forward to. That is rightly mentioned by you. So now, Doctor, early diagnosis. Let's talk about early diagnosis. So it is very crucial. So what warning signs should pediatricians and general practitioners look for to ensure timely diagnosis of type 1 diabetes?
Yes, so the warning signs of type 1 diabetes. You must have heard about the classical symptoms of diabetes, like people drinking frequent water, like they're feeling thirsty, or they are peeing a lot, they're losing weight, children who are having bedwetting issues. So these are warning signs that it could be possibly diagnosis. Diagnosis of type 1 diabetes. And some children may unexpectedly, they will be healthy and they will get some minor infection like an upper respiratory tract infection, and they start vomiting. They may have abdominal pains. You can suspect it could be a diabetic ketoacidosis, and in that case, you should always check blood sugars. Blood sugar is one of the vital signs. Like you check pulse, blood pressure. You check during the COVID times. People used to check, their SpO2 levels with these kind of devices. Similarly, you should check for blood sugar. So these are the warning signs that every doctor, even parents, should be aware of. If their child is peeing a lot, drinking a lot of water, bedwetting, not gaining weight, feeling fatigue all the time, having very poor scholastic performance, you should look for these. You should consider going to a doctor and testing for blood sugar.
This is really a practical advice. So before we go to the next question, doctor, I would like to take one audience question, that is, what dietary habits promote a balanced lifestyle for children with diabetes?
It's a very, very good question. Most of these children, they have always been deprived of the normal food. So when somebody gets a diagnosis of type 1 diabetes, their families, their relatives, they completely stop them from eating, sweets, ice creams, chocolates, juices. They are not allowed to, touch sugar. That is not the case. A type 1 kid can eat anything, whatever a normal child who doesn't have diabetes. There are no dietary restrictions. But you need to understand that you have to do an appropriate carb counting. You need to know which food can impact their blood sugar. So you need to appropriately adjust the dose of their insulin. But there are, as such, no restrictions. Like any other child, they can eat healthy food. Healthy, I mean, which will have appropriate amount of carbohydrates, appropriate amount of proteins, appropriate amount of fats, then minerals, fruits, and vegetables. So just a clear message here that please do not deprive children with type 1 diabetes. Don't restrict them with tea, coffee, sugary stuffs. It's all nonsense. You just have to educate them about carbohydrates. So carbohydrates are food which get converted into glucose when they are digested, and they are absorbed as glucose. And once they enter into the blood circulation as glucose, then insulin helps that blood sugar to go into the blood cells. So that is my advice to families as well as doctors, treating type 1 diabetes.
That is such a practical and I would say a very good piece of advice, especially even for healthcare providers. So now, doctor, let's switch gears a little. So, what is the current status of immunotherapy for type 1 diabetes, particularly in halting or delaying beta cell destructions? And are there any promising trials our audience should know about?
Yes, there has been some immunomodulator therapies. There has a drug called as teplizumab, which is a monoclonal antibody. What they did that, if my audience knows that type 1 diabetes has 3 stages. Stage 1 is when the blood sugars are normal, but antibodies are positive, because type 1 diabetes is an autoimmune disease. In stage 2, the blood sugar is not normal, but it is not diabetes. It's between normal and diabetes, like pre-diabetes, and antibodies are positive. Then you have a stage 3, the clinical stage, where your antibodies are positive and your blood sugars are in the diabetic range. So they used this molecule in stage 2. So what it did, it delayed the progression of type 1 diabetes. So it delayed the progression from stage 2 to stage 3. And also, among those this drug was used who were already diagnosed with type 1 diabetes early, within first 2 years, who had a detectable C-peptide, that also prevented the progression. The insulin requirements were less. So yes, we have an option of teplizumab, but the only question here is that when would this get available readily, and what would be the cost of the molecule? And as per my knowledge, I don't think this molecule is yet available in India. And although it is FDA approved drug for management of type 1 diabetes, for prevention of progression of type 1 diabetes.
Okay. So it is actually exciting to hear about these latest research, especially the drugs for type 1 diabetes. So following that question only, doctor, one more audience question that I would like to take up here is, how do you approach adjusting insulin dosages for growing children with type 1 diabetes?
Again, very good question. So I will first of all, when I started my practice treating children with type 1 diabetes, so what we used to do is a fixed dose regime, where we will calculate the dose of insulin as per the body weight, and then we divide the dose into basal and bolus. Mostly 50% of the total dose would be basal, and the 40 to 50% would be the bolus dose. So, but what I saw, children who were on fixed dose of insulins, most of them would not achieve a good glycemic control. Most of these children, if I talk about the center from where I got trained, our mean HbA1c on fixed dose insulin was around 10 to 11%, which was very bad as per ISPAD guidelines, International Society for Pediatric and Adolescent Diabetes. We need to keep HbA1c of below 7%. So those who were on fixed dose of insulin, where people don't know how to adjust the dose of insulin, how to do carb counting, they would always have a poor outcome. But what I did when I went to Australia, so I learned a program called as SWIM, Success with Individualized Insulin Management. So the beauty of this program was in Australia, in that center, and that center is John Hunter Children's Hospital, is one of the best centers in the world in terms of the diabetes outcome. Their mean HbA1c is around 7%, even 6.5% with this program. So there, every child would have an insulin dosing card, what they call insulin card or SWIM card. So it will have a column of insulin dose, and it will also have a column of a blood sugar. So what they will do is they will, check their blood sugar. Most of them, 50% of them are using the CGM. They don't usually do this finger pricking. And then they will estimate the carbohydrate which they are eating in terms of exchanges. Then that card will guide them how much dose of insulin they will give. And that was something that we implemented in our population, and we had outstanding results. I presented those results in various ISPAD conferences. Last month, I presented this in Lisbon, and before that in Rotterdam. So our mean HbA1c after using this SWIM from 11% reduced to around 7.5 to 8%. So in my clinical practice, I put everyone on SWIM card. So very easy. So we made photographic carb counting, photographic, resources where they will have the most common type of foods that we eat here. So, for example, roti. One roti is equal to one exchange, or we have a different type of bread in Kashmir called as kandar chot. So one kandar chot is equal to 3 exchanges. So it will have a photo of that food and the approximate exchanges. So what children would do, they will check their blood sugars, and then they will see what they are eating, how many exchanges of carbohydrate they're eating, and that card will help them in adjusting the dose of insulin. So that card also helps them to give what is called as correction boluses. Normally, there is something called as correction bolus. Correction bolus is, suppose you randomly check your blood sugar and you have already taken your insulin. After 3-4 hours, you are checking your blood sugar and that is high. You need to give insulin, bolus insulin, to correct that blood sugar. Most of them are not doing that. So that card also helps them to give correction boluses. So this is what I use, and I have got a lot of good results. It basically works on the principles of insulin pump algorithm.
That is such an interesting and insightful approach that you use, doctor.
So
Now,
just one more thing I want to add. The only thing that we need to do is educate about carbohydrates. And if possible, you can teach them about carb counting. And what in my experience, you can make most commonly foods that these children have, and you can do the carb counting. Or there are a lot of resources also available. Life for a Child has made a book on carb counting for Indian foods that can also be used.
Thank you for sharing that, doctor. Now, reflecting on that, only on your global perspective, doctor, For those aspiring to make a global impact in diabetology, your journey is truly inspiring, let me tell you. So, can you share your insights about the ISPAD Science School for the Physician in Rotterdam and how it shaped
Rotterdam.
your approach to treating type 1 diabetes?
So yes, so I joined ISPAD. ISPAD stands for International Society for Pediatric and Adolescent Diabetes. It's an organization which only deals with pediatric and adolescent diabetes. So it is, you can say, one of the leading organizations in pediatric diabetes in the world. And I became a student member in 2018. Through ISPAD, I got a lot of opportunities. One of the opportunities was, as you said, I got selected to attend ISPAD Science School for Physicians. So this is a science school where around 15 to 20 students, like fellows, pediatric endocrinology fellows or endocrinology fellows, they meet and they present their research proposals, and they do a lot of networking so that they learn about other centers, how they are managing diabetes. So when I went to Rotterdam, uh, the best research presentation, they award what they call ISPAD JDR fellowship. And that time I did not get it, but the one who got it, her name was Dr. Rowan. She was from John Hunter Children's Hospital. She was mentored by Professor Bruce King. So I networked with her, and through her, I got connected to Professor Bruce King. So, so through ISPAD, I got connected to Professor Bruce King, and Professor Bruce King. Then I applied for another fellowship called as ISPAD Ellen Rash Fellowship, which I completed it in John Hunter Children's Hospital. And the program that I was previously speaking, it is the outcome of that fellowship. And once I got this, this program into our pediatric population, then I applied for another fellowship, so which is called as ISPAD JDRF fellowship. So ISPAD JDRF fellowship helps researchers to do advanced research in pediatric diabetes. So I have been very lucky to be one of the, I would say, the first Indian doctor to get that ISPAD JDRF fellowship, and first to get both ISPAD Ellen Rash and ISPAD JDRF fellowship. So I, appeal, or I would say, I request every pediatrician who's interested in type 1 diabetes or pediatric endocrinology, they should explore ISPAD. They have a lot of opportunities for young doctors, those who are under 40. They have options of attending different science schools, doing different types of fellowships, and that will really help them in improving their clinical practice. And if they are really passionate about type 1 diabetes, and if any one of them who's watching me wants some advice on how to apply for these fellowships, or how to learn the swim, or there are a couple of centers in India who have already adapted my program, and they are getting a lot of good results. And if anyone is interested, they can reach out to me. I'm always available to help them.
What an amazing experience, and thank you for sharing that, doctor. And all our audience, please feel free to reach out to doctor if you will have any questions regarding this. So now, doctor, how did this contribute to the launch of the Life for a Child program in Skins?
So interestingly, when I got connected to Bruce, so I made a presentation in Rotterdam. So in that presentation, I was basically, telling the data that we had. So the mortality rate in our population in type 1 diabetes is just less than 30 years. So what I'm trying to tell you is that children do not live 30, they die before 30 because of the poor diabetes control. If you get diabetes at a young age, like somebody who got diabetes at 2 years, by the time he turns 20, he already has an established chronic kidney disease. He's already on dialysis. By the time he turns 30, he's already dead. So mortality was very bad. Like their life expectancy is just 30 years. So when I explained them the reasons, one of the reasons was lack of free insulin. We still do not have access to free insulin provided by government. We do not have access to free blood sugar testing strips or glucometers, okay, testing for HbA1c. So when I explained this to the Bruce, and he got connected to me with Dr. Graham Ogle. Graham Ogle is an incredible person. He is the general manager of Life for a Child program. So when I discussed with him about the issues that we are having in SKIMS in Kashmir, so he started the program at SKIMS. So Life for a Child, they supply insulin to most of the world, like developing and underdeveloped countries, including India, Pakistan, Bangladesh, and African countries. They give insulin, they give glucometers, testing strips, they give HbA1c devices. They educate doctors, they educate nurses. So that is how when I left SKIMS as a PhD scholar, I made sure before I leave, I give something to this institution so that children who were not getting anything, now they are getting insulin, glargine, they're getting testing strips. And also when I implemented this John Hunter's program, the outcome is really good. So my dream is that, the statistics that showed the life expectancy is just 30 years. That should be, and a child should live a normal, healthy life like any other, even if they have diabetes.
Yeah.
So they should not die just because we couldn't help them, we couldn't provide them with better education. Diabetes education, we could provide them with free insulin and the support. So that is how it got implemented, and I'm very, very happy and very proud that it happened.
That's such a beautiful thought, doctor, let me tell you. And I think bringing global initiatives to a local level and seeing such a profound impact on children's life is incredible. Now, I'm sure that introducing these international programs can be complex. So, what challenges did you face while bringing the swim program of John Hunter Children's Hospital to SKIMS, and how did you overcome these challenges?
So the biggest challenge was, as I told you when I started, this live webinar, I said, be very careful what you teach to these families, because once they learn something wrong, it's very, very difficult for someone, to convince them what they are doing is actually wrong. So this fixed dose insulin is very easy. Like, a doctor just writes a prescription of regular insulin, like before breakfast 8 units, before lunch 8 units, before dinner 8 units, then take a insulin N or glargine of 20 units, and they continue with that. Okay, because very easy. So once you bring something new, you tell them, no, you have to first check your blood sugars, then you have to look at your plate and see how much carbohydrate does this food meal contain. Then you calculate the carbohydrate in exchanges, and then you give insulin. So initially it was very difficult, but when you spend time with them, when you show them results, like, this is working. So I had one young girl whose HbA1c used to be always about 10%, 12%, despite our best efforts. Like, we will spend, hours together in explaining her, father, her mother, but we never got, good results. So when I started this program in that girl, so for the very first time, I was surprised that her HbA1c, which used to be always around 11 to 12%, and she had diabetes for almost 13, 14 years, her HbA1c dropped to 6.5. So it was remarkable. Is because we taught them, the right thing, the appropriate dose of insulin, calculation of carbohydrates. Very simple, it looked very complicated initially, but the cards are very simple. The photographic, these sources that we have made are very, very simple. Anybody can use it. So biggest challenge was shifting them from, fixed dose to something, individualized approach. Because, in type 1 diabetes, even if you eat same thing daily, your blood sugar is same, your insulin dose will never be same. It will change. Okay, so your dose will change, your blood sugars will change daily. So you cannot be on something which is fixed. Although not everyone was willing. Those who were willing got benefited, but I'm trying that most of them should be on swim, so that we don't reach a time where somebody would tell me that this a bad news that a child died just because we could not give a good control.
Yeah,
And
I think that
also there are some other logistic issues. When an international organization plans to start up there, they want transparency. they would only invest or send money or these glucometers, insulins to the established institutions where they have trust. So and then government also does not always allow, because if there is a foreign funding, then you need to have a lot of other accounts, FCRAs. So there are other logistic challenges also we face. Some challenges are in India, they are not able to ship uh, regular insulin because of very high custom charges. In rest other places they are able to do it. In India they are only able to send us the glargine and glucometers. So government also has to be a little flexible. If organization like Life for a Child wants to help, and their motto and their logo is "No child should die of diabetes." That is their motto. So these were the challenges.
Thank you for shedding the light on those challenges also, and it is admirable of how you actually navigate those challenges also. So now, doctor, given your expertise in managing diabetes in Kashmiri patients, so could you discuss the cultural and dietary considerations you usually address?
Yes. So when I went to John Hunter Children's Hospital, they gave me a booklet. They said, we have already worked on Indian foods. You take it home and you can see the foods. But I was very surprised when I went into the book and I read that book. There was nothing about Kashmiri food. So just to give a context about Kashmiri food, like we have different varieties of breads made by our local bakers called Kandur. So they make different types of rotis. So the thickness is different. The amount of the maida they use is different shapes, different sizes, and every roti and every bread has a different carb content. So I had to make a special Kashmiri food, like a carb counting kind of a booklet for Kashmiri foods, where we have almost 13, 14 varieties of breads, and every variety would have a different carb content. So it was little difficult, but it was not. I mean, uh, I would say I should be thankful to the John Hunt, especially their lead dietitian, Dr. Kamral Smart. So I worked with Dr. Kamral Smart. She is the lead authority in pediatric diabetes. So whatever guidelines we have on diet and nutrition on pediatric diabetes, she is the lead author. And I worked with her. So I told her that these are the foods, and I brought all the ingredients from Kashmir that these breads contain these ingredients, and based on those ingredients, so she calculated the carbohydrate exchanges. So it is difficult. It was a little difficult, but I made it very easy.
This is a thoughtful approach, doctor. Now, your work with type 1 diabetes children in Kashmir has been remarkable, doctor. So, how have initiatives like the Life for a Child program impacted their lives?
See, the first thing, I'll tell you a story. I think in 2017-18, I was in my OPD. We used to stress on blood sugar monitoring, like whatever children used to come to us. We used to tell families, no, you have to check multiple times. You have to maintain this SMBG log. Once I saw a young boy, and he bought his this SMBG log, but the numbers that he had put, like they were all uniform. Like for example, fasting 100, post-prandial, post-breakfast 130, 130, 130. So it seemed that he had cooked it. He was scared that if I will not show my log to the doctor, he might scold me. So when I tried to do some kind of to understand why he has done it, I was it was so shocking that his father could not afford a glucometer and a testing strip, and therefore he wanted to see a doctor, because doctor will scold him and you're not doing blood sugar monitoring. So he put the wrong numbers, he cooked it. And this was one of the I would say one of those moments which you know uh, I asked myself that how can I help this. And that's how the story behind Life for a Child started. So when Life for a Child came, now what they gave a free glucometer, they gave 3 testing strips free of cost till you turn 25, so you can check your blood sugars. They gave insulin also. So once you're giving them with insulin, once you're giving them a glucometer, now they don't have an excuse. Okay, some may still have excuse. And once you're checking your blood sugar, now you know where you're going. Either you're going high, or you're going low, or you're going normal. That is, SMBG will guide you. So once they started doing it, automatically your HbA1c will start going in the lower range. So research says if you reduce the mean HbA1c by 2%, you can reduce the diabetes-related complication by half, just by reducing their mean HbA1c by 2%. So we are already there. We were 12, 11, we are in 8. And I'm sure if this program is implemented in a nice way, like it should be, incorporated into the scholars who are fellows in endocrinology, I'm sure that we will have outstanding outcomes, and our center can become one of the best centers in India. And all the centers can have a good outcome if you just do simple things. So Life for a Child has made a remarkable, I should be, thankful to entire team of Life for a Child, what they did for us and what they're doing, not only in Kashmir, in other parts of India also. Life for a Child is there in Gujarat. They are working in different parts of India as well, not just in Srinagar, in Kashmir.
Yes, that is such so incredible, doctor. And I think the program like this is truly that makes it heartwarming as well. And it's also so incredible to see how lives can actually be transferred with the right kind of support also. So now lastly, doctor, from my end, if you could give one key takeaway for our audience today to better support children with type 1 diabetes, what would that be?
See, type 1 diabetes is something that will not give anything to the doctor financially. You will be surprised to know that most of my patients who see me are treated free of cost. Okay? You need to, it's like treating type 1 diabetes is like a charity. You need to be very passionate. You have to be very empathic with the patients, with their families. And you need to have time. I have given, I'm giving you my example that I give one entire day for type 1 diabetes, which is on Thursday. So Thursday is for type 1 diabetes. Whether now I'm not in skims, I'm in my private practice. So when they come to me, I see them free of cost, not because they cannot afford, but it's that emotional attachment with these children. I have seen children like getting diagnosed at the age of 11 months. Now he's 10 years old. I have a picture with him and he was just a baby. Now when he comes to me and takes a picture, he's 10 years old. Now you can just imagine these children who are growing into adults, and some of them are doing so good. Some of them are doctors, some of them have become engineers, some of them are doing jobs, some of them are lawyers, some are doing business. So they're excelling in their careers. So the message is, if you are really interested, join organizations like ISPAD, make a separate pediatric type 1 diabetes clinic, approach international organizations like Life for a Child, JDRF. They are there to help. And those who have learned, you can take help from them as well. For example, if somebody is really interested, they can contact me. I am more than helpful. I can go and visit their centers. I go to different conferences. I teach the concept of swim to other doctors, and they find it so easy. They are so happy that they don't have to do anything. This carb counting calculation is so complex. Trust me, I have also not learned it so well, because when you put on calculations, but when you make something tailor-made, simple, so it helps. So be passionate with children with type 1 diabetes and be very patient.
I think your dedication is something that is very admirable, doctor, and thank you for that beautiful advice to all our healthcare professionals. So before we wrap up, doctor, I'd like to take a couple of questions from the audience.
Yeah.
So we have one question. The doctor is asking, what are the key tips for maintaining blood sugar control in children with type 1 diabetes?
So when I was in John Hunters, there were 10 tips they used to tell. So I don't remember all tips, but I'll tell you a few of the tips. So always inject insulin before meals. Okay. So when you inject, it has to be before meals. Check blood sugar multiple times a day, minimum 4 to 5 times a day. Okay. And know the food. If you know the food, if you know what food contains carb, I think 30 to 50% of your job is already done. Then if you can estimate the carb counting, you can do that, 80% of your job is done. Give correction boluses. Never skip insulin. Even if you are sick, never skip insulin. Tell your patients that don't skip it. Even if they are vomiting, tell them take, they reduce the bolus insulin by 50% and, take sips of juices. And long-acting insulin, you should never stop. And educate them. The more you educate them, don't just presume this kid has type 1 diabetes for 10 years, he would be knowing everything. I have seen many parents doing blunders. So always check whether they are actually injecting, whether they are injecting at the right site. And also one more thing I learned was, these small children, when they grow up, in initial years, insulin is given by their parents. So once they grow up, they turn 8, 9, 10, they become independent. Then they think that they can manage on their own. But you should always check once you take insulin, either in a syringe or a pen, or somebody else should cross-check the dose of insulin to see whether he has taken the right amount of insulin. He has not, taken less or even high amount that prevents those accidental hypos. So always under supervision. Even in the hospital setting, when I was in Chandler Children's Hospital, one nurse used to, put the dose, and the other used to cross-check it whether the dose is fine. So just to miss those, accidental errors. And that's it.
Thank you for sharing that, doctor. One more question is, how can we support as healthcare professionals the emotional well-being of children and families post-diagnosis?
See, we as healthcare providers have to give right information, and we have to counsel them that, this is not the end of the world. Though this is 24/7 diabetes, you need to depend on insulin injections. But if we are giving good glycemic control, good diabetes control, we will not have complications. I don't talk about complications to my patients, because actually the whole crux is behind prevention of complications. Okay, microvascular complications, blindness, kidney failure, neuropathy. So many things are associated with diabetes. So we need to tell those things in a dilute way. So just tell them you are as normal as any other child. The only thing is that your pancreas is not making insulin, and insulin is normal. It's a natural hormone. Your body is making it. And the insulin that we are giving is also natural. It's a human insulin. And if you take a right amount of insulin, if you will grow normally. And it's very true. If your insulin levels are normal, your blood sugar is normal, your growth will be normal. If you have high sugars, insulin levels are not normal, you will not grow. So they get growth issues as well. Their puberty is delayed because of uncontrolled sugars. So always be very aggressive. Do not say that he's a child, in future we'll see how to manage the food. It has to be from the day one. You have to be right on the target. You have to have a very good glycemic control right from the day one. Don't wait for 10 years and then we will explain. I have seen people telling, oh, he's a child, how can you stop him from eating this? And okay, he's a child, I would stop him from eating ice cream or a chocolate. Don't do that.
Thank you, doctor, for sharing that. And as we wrap up today's live webinar, doctor, thank you so much for sharing your insights and expertise with us. And let me tell you that your work is truly inspiring, and I'm sure our audience has taken away some invaluable lessons from today's session. I definitely have, doctor. So thank you
Thank
so
you
much for
so
sharing.
much. Thank you so much for having me here, for giving me another opportunity to talk about my favorite topic. Thank you, and thanks everyone who joined today, and thanks for all your questions. If there is anything that you need, you can directly reach to me through my LinkedIn, through my social media, So whatever way you can approach me, I'm always there to help, including people living with type 1 diabetes.
Thank you so much. And to our attendees, thank you for joining us today. And let's continue working together to build a better future for children with type 1 diabetes. So until next time, take care and stay safe, everybody. Thank you.